Thank you, everybody, for joining us. It's great to have you all here. I'm Sandro Galea. I have the privilege of serving as Dean of this great school of public health. This symposium is one of a series of symposia that we have launched this year that we, on the occasion of our 40th anniversary, but that we plan on continuing going forward. And the notion is that we bring together experts in areas that are close and dear to the mission of the school in order to really understand where the global conversation is at on particular topics and to contribute to the global conversation. We had a symposium a few months ago on Beyond Ferguson, looking at issues of race in America, and today's symposium is on another issue that is just as much a core part of the mission and the thoughts of the school as is that one. In your program, you'll also see the programmed future symposia, and there are some other symposia which we will add to the list as we move forward. I just want to make a couple of comments about today's topic. So today's topic is about public health and human rights. And it is a topic that I have long felt that should be very much at the core of any intellectual public health, population health agenda. It is a topic that should be animating what a school of public health does. And it is a topic that Professor Annis will introduce in a second, and I have argued should be very much at the core of the mission of public health as a discipline. I had a chance this morning with some help to look at some data which I wanted to share with you, which really highlight how much a topic like human rights is very much at the forefront of the global conversation and should be even more so. So just by one example, as of today, there are about 4 million Syrian refugees living in neighboring Middle Eastern countries. Many of them live in appalling conditions. In urban Jordan, for example, Amnesty International estimates that 86% of refugees live below the local poverty line. Now, with that, hearing that, in the past couple of months, Donald Trump, who, as you know, is the leading contender for Republican presidential nomination, unless the Wisconsin wall gets in his way, when he weighed in, he said, when asked whether he would let refugee children attend American schools, he said, "I can look in their face and say, you cannot come here." Mr. Trump has also advocated targeting and killing the families of terrorists, which is a war crime. But it's actually easy to pick on Donald Trump, so let's not. Although, just do it and then move on. But yesterday, Mississippi, Governor Phil Bryant of Mississippi signed a new law that in the name of religious freedom lets organizations deny services to people based on sexual orientation. So these are very much, I'm just picking American examples just because I always feel like we should pick on our own. These are just two current examples of how we have at the highest level of governance, at the highest level of politics, efforts that are in direct contravention with human rights as they are currently accepted. I think health has entered the human rights arena in the past several decades in no small part due to efforts of faculty here at the BU School of Public Health, in no small part coincident with the HIV epidemic. But I think today's symposium represents a way for us to take measure of the challenges that we face. It's a chance for us to understand where we have been coming from, but look towards the future, where human rights are respected and upheld. I think it's going to be a fascinating discussion. We have really, I think, the leading thinkers in the field on this, and I'm tremendously excited about today's conversation. Thank you all for being here. I will quickly introduce Professor Annis, who is the brains behind today's show, and is going to serve as the Master of Ceremonies. So almost everybody here will know Professor Annis, but for the sake of ceremony, which is important, he is the William Fairfield Warren Distinguished Professor at Boston University. He also directs our Center for Health Law, Ethics, and Human Rights at the School of Public Health. He is a member of the Department of Health Law, Policy, and Management. He has been a professor here a long time. He's the author and editor of 20 books on health law and bioethics, including the second edition of Public Health Law. He's also the co-founder of Global Lawyers and Physicians, an NGO dedicated to promoting health and human rights, and many, many other things. When I first moved to the School of Public Health, and when I had no office furniture for, it seemed like many years, the only book I had in my office was Public Health Law, which I thought was fitting because it really symbolized, as far as I'm concerned, how central law is to the practice and scholarship of public health. So I'm thrilled to have this gathering here today, and I'm very grateful to George for organizing it. Professor Annis.
Sandro, thank you. I'm happy to be here. I'm especially pleased at the very extremely strong group of speakers we brought today, and I'm sure you will be too. I'm going to take a few minutes to give you an overview of what's going to happen today, and then I'm going to not do what Sandra just did to me. I'm not going to give lengthy introductions or much introductions at all to the speakers because you have your programs. This is a program, I'll tell you what you have. And in that is a 1 page about each of the speakers you're going to see. So you can look at that at your leisure, and I won't repeat that. You have some other things at your chair. We have that you can refer to during the day. One is a major public health and human rights documents. There actually aren't very many of these. We could have done a whole booklet. But you have the Universal Declaration of Human Rights, which you'll learn about. Most of you know about it in a second. We have the health definition from the preamble of the Constitution of the World Health Organization. And we have Article 12 of the Covenant on International Economic, Social, and Cultural Rights, which is the right to health provision, which we'll be talking about in detail today as well. The other thing you have is, this will be for this afternoon, a letter from our speaker this afternoon about Guantanamo, an open letter to close Guantanamo. We'll talk about that this afternoon. And then you have some cards, which we'll see whether we use or not, but I think we probably will, where we want to poll the audience. At times we'll be polling the audience, and I hope you can figure out for yourself that green means yes, red means no, and yellow means I don't know what the hell you're talking about. Okay, so, but the point of that is that we want this to be very participatory, all right? We only have really 2 speakers. People are actually going to stand up and talk to you, for 30 to 40 minutes. One opening in the morning, a rapporteur on the right to health, and I'll introduce him in a second, and one in the afternoon, a rapporteur on torture. And we're going to follow that with a discussion of some of the leading experts on these various topics after each of those 2 speakers, and then we're going to open it up to everyone here. And we'll spend at least a half hour to 45 minutes of the morning and the afternoon in open discussion on these issues, because we really want to hear what you have to say. And we also think that we're going to have a little minor debate, we had one last night, on some issues about health and human rights, how central human rights are to public health. Is there really a difference between medicine and public health, and how does that matter in the field of human rights? And is it useful at all in the United States to be talking about respecting, protecting, and fulfilling economic, social, and cultural rights? Are we just a political and civil rights country? Do we just care about rights like free speech, et cetera? So all those things will be major topics. I'm going to begin with a quick overview of human rights and public health, with the goal of making sure we're all on the same page. I'm not going to ask you to hold up your cards, but for most of you, hopefully most of you, this will not be new. This will be review. But in any event, I want to do this before we get started. This is one person's view, but I think it's a pretty good one, of the history of human rights, the eras of human rights, which all had its birth in World War II. I mean, we can trace back, Plato and Socrates, but we don't have to. Real modern human rights began with World War II. It's called the era of universalism, when we recognized that we're all the same. Right? We're all members of the same species. We all have human dignity, and we should all have the same rights. Era of institutionalization, and this is Harold Koh's breakdown. When we set up the institutions that could protect human rights, the era of operationalization, when they actually started to go out into the world and operationalize human rights. The era of globalization, which is dated sometimes from 1989, the fall of the Berlin Wall, right? And then after that, we've been living through the era of optimism, which I think is right, the 90s, when democracy was going to be triumphant, up till 9/11, when the era of pessimism began, then the first Obama administration, hope and change, and the second Obama administration, despair, but there's a question mark there. We don't know whether we despair or not. I'll leave that to you to say how we're doing now, all right? But the beginnings were really Franklin Roosevelt. You have to give Franklin Roosevelt immense credit. It's for freedom speech in 1941, which is why 1941 is down there. Freedom from want, fear, freedom of religion, and freedom of speech ultimately grew into the Universal Declaration of Human Rights. Wait a second. Which he was dead, obviously, at the end of the war. But when the UN was formed, and he certainly is responsible for, largely responsible for that, so the U.S. Support of it, his wife, his wife, Eleanor, was the chairperson of the drafting committee of the Universal Declaration of Human Rights. Again, we can argue about this, but I think that's mostly believed to be the most important human rights document ever, and that's one reason we put it in your materials, to make sure, because we'll be referring to that a lot today. Berlin Wall, again, very symbolic of human rights, and the release of Nelson Mandela and the end of apartheid. Two giant occasions in the history of human rights. The era of despair is, of course, the United States and Guantanamo, which will be one of the main subjects for this afternoon. What rights are we violating in Guantanamo besides the right not to be tortured, et cetera? And we'll talk about that this afternoon. After World War II, there was not only the documents, but we had trials, first international trials ever at Nuremberg. And you all know the Nuremberg Principles, whether you know their name or not. You know that there are such things as war crimes and crimes against humanity, murder, torture, slavery being some of the main ones. Individuals are responsible for committing them and saying, I'm just obeying orders, as our CIA has done many times, is not a defense. It's no defense. Right? And again, we'll talk about that in detail. We'll talk about the role of physicians. This is from the doctor's trial, what physicians are doing in the neighborhood of torture, force feeding, et cetera, and how human rights might be used to redress that. These are the most important human rights documents. They'll come up. Again, the Universal Declaration of Human Rights I put right up top, the Geneva Conventions, the International Covenant on Civil and Political Rights. These are important, but these are three that the United States has not signed: the International Covenant on Economic, Social, and Cultural Rights, the Convention on the Rights of the Child, and the Convention on Elimination of Discrimination Against Women. We're actually the only country who hasn't signed this convention, and one of the few who hasn't signed the CEDAW. These are two we have signed, though, which we'll talk about later. The Convention Against Torture will be a big topic this afternoon, and the Convention on the Elimination of All Forms of Racial Discrimination. We haven't eliminated all forms, but we've signed the convention and pledged to do that. Right? I won't go into this in detail, but just in general, we think of bioethics as the ethics of the doctor-patient relationship. We think of health law as national law and state law, and we think of human rights as global, what I call species level and usually treaty-based. So, but they're all interrelated, and we'll see that. This is a slide for discussion and thought, but whether there is a difference between medicine and public health and what it is, but in general, I'm going to argue, and other people may or may not agree with this, that human rights is the right ethic for public health, just as bioethics is the right ethic for medicine. And we obviously deal with populations, prevention, and social justice. This is a question we'll ask this morning especially. Does poverty matter? Is the right to health really more based in class and social and economic conditions than anything else? And should we concentrate there? The right to health got a big boost with Jonathan Mann's concept, and he wasn't the only one, but the main one, of health and human rights. And health and human rights are inextricably linked. And we'll try to talk about what that means. This is a picture that the WHO put together that noted in the right to health, the underlying determinants of health, we all know that, are not medical care, but are food, nutrition, housing, et cetera, the socioeconomic conditions, which we'll talk about. The health and human rights framework has been suggested as the right one. And again, we'll argue that because it's universal, it's based on human dignity, it is enforceable in some means, it includes the right to health. The non-discrimination principle is its core, all humans are equal, that you just can't do anything in human rights without accepting that core principle. And there's special obligations to women and children in human rights land, which makes it, again, especially suitable for public health. This is from comment 14, which is the committee's explanation of the right to health, and just two things I want to pull out of that. That it extends to the underlying determinants of health, such as food, nutrition, housing, access to safe and potable water, adequate sanitation, safe and healthy working conditions, and a healthy environment. Again, that's public health writ large. And then number two, it contains both freedoms and entitlements, including sexual and reproductive freedom centrally, the right to be free from torture, non-consensual medical treatment, and experimentation. Again, the morning we're going to do the right to health, the afternoon we'll do those freedoms. And the right to health, like all human rights, imposes three obligations on the state to respect, protect, and fulfill human rights. These are alternate overviews you can use to look at public health. I suggested the human rights one is the one we'll spend most of our time on today. But it's very closely related to social justice. And we'll be talking about how related they are, what the differences are between human rights and social justice. Bioethics, we suggested already, is really the doctor-patient relationship. Economics, which usually rules the day, based on efficiency, utility, cost effectiveness in the market. And then politics, when we're in the middle of that now, which is, well, you tell me what it's based on. But theoretically, it's based on the will of the people, right? But again, today we're going to look at the universality of human rights and how it can be used to guide and help and advocate for public health. And I'm delighted to bring up our first speaker, Dennis Pouras, who is the UN's Special Rapporteur on the right to health. He's only the third rapporteur on the right to health, whose job is to explicate, advocate the right to health, what it means, and also to go to specific countries and make reports on how they're doing with the right to health. Well, let me let him explain what he does. But let me say, we're just thrilled that he could come and be with us today. He's from Lithuania, and so he's our furthest traveled person today, too, as well. Dennis.
Good morning. It is a great pleasure and privilege for me to be here with you. I will try to share my understanding, my vision, my insights from first 1.5 years serving as a special rapporteur on the right to health. And I hope to provoke a good discussion. I was happy to have two very good distinguished predecessors, Paul Hunt from New Zealand, now working in the University of Essex, United Kingdom, and Anand Grover from India, both lawyers. I am the first medical doctor who is a special rapporteur on health. And Paul Hunt said this with other experts, set what is called analytical framework, which is very, very useful in while working for this mandate. Just very briefly, he told that primary objectives are to promote and clarify right to health and to identify good practices. It is important to mention that right to health does not mean right to be healthy, because we know that there are many reasons not to be healthy out of our control and out of even government's control. But this is about right to enjoyment of the highest attainable standard of physical and mental health. And this is not only about right to appropriate and timely medical care, but this is about determinants of health. These are only half of elements of this analytical framework, and it includes both progressive realization. It talks about progressive realization of this right, but also that many issues, many obligations should have immediate effect. And what was already mentioned, it's about respect, that governments need to respect, protect, and fulfill. Health care should be available, accessible, acceptable, and of good quality. Very important issues are non-discrimination, I should say zero discrimination when we talk about how to eliminate HIV/AIDS by 2030. So I think that one of main preconditions is to reach zero discrimination and to start from health services, zero discrimination in health services, also equality. And last but not least, especially important, monitoring and accountability. Without accountability, all these good ideas are just empty promises. My predecessors submitted and presented very good thematic reports. Just briefly, we special rapporteurs, we belong to special procedures mechanism in United Nations. We are not even part of United Nations. United Nations appoint us to serve as independent experts. So it's interesting combination that it's difficult to tell, are we UN or not UN? Actually, we are not UN. We are appointed by UN. We are independent even from UN. And then our main working methods are thematic reports, which we present to Human Rights Council in Geneva and to General Assembly in New York. Country missions, and then reporting on these country missions. And communication procedure when we submit different kind of letters to governments, usually when we receive complaints, and first we go confidentially, then we may decide to go public with some public statements. So my predecessors had very good thematic reports on indicators and benchmarks, health systems, health and human rights movement, access to essential medicines, sexual reproductive rights, different vulnerable groups such as persons affected by HIV/AIDS, LGBTI, we should say now, disability, persons with disability, substance use and abuse, elderly people, migrants and refugees, and also reports on underlying determinants of health. When I started in 2014, in my first report, I told that my activities will be guided by these words of Jonathan Mann. The human rights framework provides a more useful approach for analyzing and responding to modern public health challenges than any framework thus far available with the biomedical tradition. I deeply believe in this, and having worked many years as medical doctor, I was sadly surprised before I could read all these texts how unfriendly is medical practice to human rights, and how difficult it is to explain to many people how it comes that you, as a medical doctor, suddenly are interested in human rights. It's some exceptions, you look like a dissident a little bit, right? And some people tell that maybe you even are betraying medicine. So it's interesting and sad observation. My my vision is biased by my background. I think every special rapporteur brings something from his or her background, and my background is having worked with children with disabilities, also having actively been involved in reforming mental health services and policies, mainly in Central Eastern Europe. But also coming from this region of Central Eastern Europe, which I may tell some words about this later. And my idea was to work further with the operationalization of right to health, addressing existing imbalances and power asymmetries. There are a lot of perfect documents, global, regional, national, legislation, studies, documents. In these documents, everything is perfectly told what should be done. And then during implementation, something happens. Somehow these good ideas are diverted through corruption, through different wrong incentives. And so we see very often departure from these good ideas, which should be guided by a human rights-based approach and modern public health approach. A lot of evidence we have how we should invest in health, in individual and societal health. So these imbalances can be in healthcare systems when specialized medicine dominates over public health and primary care, it should not be so. These imbalances may be between stakeholders, then when sometimes medical doctors, elite of medical doctors control even governments in some countries. Should not be so. And so I started to address these imbalances and power asymmetries. Especially is important at this moment when we are participating actively in the transition from MDGs to SDGs. I hope most of us know what these words mean. And now we have Agenda 2030 or post-2015 agenda. And one of goals in these SDGs is to reach universal health coverage, which I think is very important also to your country. So one of approaches I took on board was life cycle approach. Maybe it was easier for me to start with my expertise in pediatrics and childcare. And I have reported already on right to health in early childhood, and now I will report in June to Human Rights Council on right to health in adolescence. Also, mental health and emotional well-being is one of my priorities, rights of persons with disabilities, and I would also like to contribute on violence, which is both a human rights problem, but I firmly believe in violence as a public health problem, and the solution to epidemics of violence is mainly through public health approaches and not through so-called mad or bad approach. I will comment on this later. So when we address these imbalances and we see how many governments are moving to selective approaches. By selective approaches, I mean when position is taken to take care of one group of rights and to ignore some other group of rights. So when I was looking at the Berlin Wall, my memory came also to 89. This was in 1990 was the first time when I could finally cross this iron curtain. So I was waiting for 32 years. I was living on other side of Cold War. So but my thinking is influenced by this Cold War situation when two groups were fighting about what does it mean human rights. So East was accusing West and West was accusing East, and both were wrong. But the paradox is that people like me, being on other side, were in their hearts with what the West was talking, and those who were in the West were on the side of what East was talking. So it happens so. But I understand very much that the right to health is firstly economic and social right, but I am very passionate because of this background and very sensitive about when civil rights are forgotten. This was what the Soviet model was telling, that they solved all problems, including health problems, just you could not be free, you were not allowed to think and speak, and this I don't think this is a good idea. Inequality and discrimination, meaningful participation, these things suffer if some part of human rights, universal human rights, is sacrificed. So if there is a lot of polarization, if some people are very rich, some people are very poor, then those who are very poor cannot meaningfully participate. And the same happens in other scenario when people receive some minimal standard of safety and social security, but they are deprived of the civil and political rights, which happens in totalitarian systems. So for me is also very interesting this role, this balance between specialized medicine and on the other side, prevention, promotion, and primary care. And I would like to lobby for revitalizing of Almaty and Ottawa ideas, which sometimes seem that maybe not fully forgotten, but really very good ideas should be implemented. Health in all policies means that, of course, a healthcare system cannot solve all health problems, but I think that health system and health sector should be leader in all these good multi-sectorial attempts. So I started from early childhood, and my contribution was like this. Okay, I agree that right to life and survival is extremely important, and I am happy and I commend this global commitment to reduce high rates of infant and under 5 children mortality. We achieved globally a lot. We had not long time ago 13 million young children dying per year. Now we have less than 6 million. Still a lot, but reduction is huge. But my contribution was, does this mean that we stop at right to life and survival? Right to life and survival? I do not agree, because for me, right to holistic development is equally important to right to life and survival. So my report on early childhood was emphasizing that right to healthy development, holistic development, not only physical, but spiritual, moral, emotional, social, cultural, is equally important, and it is not a luxury, even in developing countries, to invest in, let us say, psychosocial interventions, or some interventions to families, that parents have some skills to behave with children in a non-violent way. This does not happen per se. Somebody delegated from state has to help parents to understand how to raise their children and how important is emotional connection. And I'm happy that now it is a new wave of research about early childhood adversities and about importance of toxic stress. And this new wave of research, 60 years after what John Bowlby told about attachment, now with neuroimaging techniques, researchers can see that actually quality of brain depends on quality of interaction between baby and primary caregiver. And if this interaction is of low quality, and if toxic stress happens, then we do not remember our first 3 years. Human beings do not have this ability to remember first 3 years, but our body will always remember how this unhealthy response to stress. And current scientific knowledge tells that the main cause of epidemics of non-communicable diseases is what is happening with human beings during first 3 years of age. It's about unhealthy response to prolonged toxic stress. So I think this is very important even to physical health. Well, some minutes about mental health. Good mental health is not just absence of mental disorder. Time has come for parity between physical and mental health. Too long mental health has been neglected, ignored, and the price we pay for this is very, very high. I think it's time to contribute with informing United Nations and governments that we may be again in a crisis in mental health care, because the many promises of biomedical or neurological biomedical model, there were very many promises that soon we will discover what is happening there during all these DSM or ICD diagnostic categories, but as we know, we do not have any single biomarker so far in mental health care. And it seems that biomedical interventions do not work so well as it was promised. So what instead? Of course, nobody suggests to go back to psychoanalysis, but it's time to restore balance once more again in history of mental health care between biomedical and psychosocial interventions. And I think it's good time for social psychiatry to be back in a very serious way. Also, there is a very interesting and meaningful discussion about using of force in mental health care and about how to interpret Convention on the Rights of Persons with Disabilities. It's a long story. Maybe my colleague Juan Mendes also will touch upon this, but he started this very meaningful process of addressing global psychiatry, that there is too much violence in mental health care settings. Now I try to continue this and talk to my colleagues, but as special rapporteur, that psychiatry should not be keeping its powerful monopoly of power with two arguments, which are this power is based on relations with big pharma, which is, I think, not very healthy power, and power is based that governments delegate to psychiatry the function of social control, which I do not think that medicine should be involved in this. And then with this I want to say that psychiatry should recognize that modern psychiatry is in crisis and some things should be revisited. It is a very interesting dialogue going on about all this. Violence Violence, starts from very small things and people ignore this. And then when we move to atrocities, then people are very, very angry and they want to punish those perpetrators. But I think it also comes from evidence from public health that the largest tragedies are caused by accumulation of small or minor cases. So it starts from families, from love of mankind to violence. For example, only 40 countries, which is 1/5 of UN member states, so far have banned corporal punishment of children, physical punishment. So, and it's now in fashion and globally and even in Human Rights Council, so-called traditional family values. I know that in your country also there's one of possible reasons why United States do not ratify Convention on the Rights of the Child is this wrong opinion that this convention is undermining authority of family, which is not so. But so-called traditional family values, they are against the rights of women, against rights of children, adolescents, and they put some family value higher than rights of individuals to be, for example, free from any form of violence. So this is very serious, these retrogressive tendencies, but we have even resolutions on this in Human Rights Council. So violence against women, against children, against different vulnerable groups like LGBTI, violence in healthcare settings cannot be tolerated. Civil society, I don't want to dramatize this, but this common agreement among us independent experts that space for civil society globally is shrinking. The situation of people who are human rights defenders is becoming very difficult in many countries in the world, and this is alarming. Many case studies and many reports are waiting for me. I have no time to now, maybe during discussion, to elaborate on what, for example, Ebola outbreak could mean, or about my country visits from Malaysia and Paraguay. Maybe just 2 short comments. Malaysia was my first country visit. This country which has not ratified international covenant on economic, social, and cultural rights, but they invited me, and I think that maybe someday special rapporteur could visit United States of America also. Would be interesting visit. And in Malaysia was my first visit. What was interesting that Malaysia has a very good healthcare system, including both specialized and very good primary care network. But this was not what I wanted to emphasize. I wanted to look broader at right to health. I wanted to go to migrant detention centers. I wanted to visit indigenous peoples. And well, then picture is not so beautiful. So in Paraguay, country is doing its best. It's improving, but one very sensitive issue was sexual reproductive rights. At that time was a case of a pregnant 10-year-old girl, which was not allowed to terminate pregnancy. And well, I qualified this as a forced motherhood. And of course it is a grave violation of physical and mental health of a child. I mean, of this girl, of this mother. Let's see. And this was not the only case. There are 700 such cases. in small country per year, and this is so it's combination of very restrictive anti-abortion laws, epidemics of violence against children and women, and it's moralistic attitudes when children are not allowed to receive comprehensive sexuality education in schools. So we have very clear effect, very clear outcome, and the recommendations are very clear, but there is some feeling that many countries do not think to implement this recommendation because it's not about evidence, it's about ideologies. And then it is very difficult to special rapporteur has to inform what is the best way, and he or she cannot change the world, and it's up to governments to make their decisions. Eastern Europe, just I mentioned a little bit, but this is all regions are special cases, of course, but just to understand for you where you have one extreme, I mean United States, you have not the best healthcare system in the world, and everybody understands this, but you have to know that there is another extreme, and I'm coming from this another extreme, when everything was for free and for everybody, and the state told you even don't have to think. We will do everything for you. Just sit down and shut up, and everything will be okay, unless you become not loyal. If you become not loyal, then you will be in problems. So this is this other scenario, and I do not want the SDGs to go this way, that such countries will report that they have accomplished universal health coverage, for example. So for me, democracy is a precondition for realization of SDGs. For me, democracy is a precondition for realization of right to health. And in this case, United States of America is not the worst country in the world, and you have to know this also. So where we have been, where are we now, what is the future? I am moderately optimistic. I don't think we should declare end of the world. It's for others to have this all moral panic attacks. It's, our opponents are using moral panic when it comes to drug use or other things. This is a method to announce moral panic and then to go to punitive, repressive measures. Actually, there is some evidence that the scope of violence is decreasing in the world. Just through media, we are informed all the time about acts of violence. But if you compare how much violence was 50 or 100 years ago, so now world is more free from violence, especially if we think about women and children and how they lived, let's say 50 or 100 years ago. So this is good news. Not very good news is that we are not very good globally in implementing this very good evidence and implementing this powerful combination of two powerful vaccines, as I call vaccines, is human rights-based approach and public health approach. This combination is very powerful, and if it is implemented in sustained way, we can really create new miracles, so to say, but not through biomedical model, but through public health approach. So these my proposals, which I just created this morning, is in Boston, is zero tolerance to violence without exceptions. No hierarchy in human rights, so that we do not go these two extremes I mentioned to end this proliferation of selective approaches like traditional family values and others. For example, to replicate success, okay, let's tell a relative success story, but still I think it's a success story with HIV/AIDS. If we have no realistic goal to eliminate these epidemics by 2030. So why not to replicate this story in other areas like non-communicable diseases, mental health, and so on. But for this we have to have mobilization of many people in the grassroots and political will, and if these two movements meet, like this happened with HIV/AIDS, then we really can achieve a lot. And to convince policymakers, medical doctors, again, because I am like a spy in health. Why? Not like a spy. I am a spy in healthcare system. I know a lot how medical doctors lobby governments, but not for those goals which we would like to have here. For some other, there are some other incentives, and so this all sounds like dreams, but we all know from history of our nations, from history of mankind, that it happens that the dreams come true. Just there is a need of critical mass of committed people who have a goal and who have a good plan to how to reach this goal. So I think that in general we are on good track, and thank you for your attention.
Yes, thank you very much for that. That really gets us off to a terrific start. I'm going to ask the panel to come take their chairs, but while they're doing that, our speaker's open to a couple of questions if you have some. We have a microphone or two coming around. Just raise your hand, we'll bring the mic to you. And if you could identify yourself, just because this is live streaming and being taped and all those good things. So if you don't want your name used, don't ask a question. Or come up after the break. Yeah.
Darius, that was a great presentation. Thank you. Just a very quick question. Can you explain your second bullet? I think that's actually an important bullet, but I'm not sure I fully get it. The hierarchy, no hierarchy in human rights. I mean, you talked about the traditional family values, but it strikes me as a very profound point, and it seems worth a couple more minutes on it.
Well, no hierarchy in human rights means that all human rights are interdependent, and there is not so that one right is of higher value than other right. So some people or some governments will tell that economic social rights are more important than civil and political rights, and so I do not agree. Maybe some governments will tell other turn around. So all these problems with the wrong implementation of good ideas start when some hierarchy is established, and policies are driven only by implementation of some of the rights and by ignoring other rights.
Question is, how does one deal with conflict when the rights conflict with each other?
Well, it's a good question. For example, this conflict which I just mentioned, which is going on now, very productive, constructive conflict around mental health care, is that everybody will agree that right to receive treatment can be very important in severe mental health condition. And psychiatrists tell that this is highest priority. Then other group, let's say human rights advocates, users and survivors tell, no, stop. Do you want to do this by using force, by depriving people from dignity, we do not allow to do this because the highest right is right to be free from any form of violence. Then probably we arrive at decision that they are equally important rights, and then it is just technical solution how then we go. And we are this morning with Juan Mendes, we are thinking what to do with this because we do not know solution at this moment. But this, I think, is a good method for humanity to progress, because this is a very clear question mark how to proceed. The serious question is, it really, for me, very important, interesting question is, do we really think that evidence-based methods work if they are applied with force? So,
No, that's, you say it, that's a contemporary, tough issue. Dr. Brown?
Hi, I'm Beverly Brown here in the School of Public Health. I was intrigued by your opinion, which right at the end of your comments about you feel that democracy is a precondition to the Sustainable Development Goals and universal health coverage. And because it isn't your job to topple totalitarian governments, what does this limit our ability to make these kind of changes in these non-democratic countries?
well, in UN system, we use this different methods, and it's about tactics. It's one method which is called naming and shaming, and it not necessarily works. The other method is to be more technical. That means to work with governments as they are and to try to reach some improvement without changing their system. I am not sure if I believe in this opportunistic method, but usually this method is used because there is no way to use other methods. But maybe it is the only way. It's I just want to thank you for your question, and for me it's very, very, very important and rather painful question.
Let me ask it a little differently. You've been to Paraguay and Malaysia. Would you go to China if you were invited to report on the right to health there?
Well, I would consider this possibility, because of course it would be very, very, very interesting visit. But then when we plan to go to countries, we have a very interesting preparation phase when it is getting clear how meaningful could be this visit. Because usually special rapporteurs want to go to other places, not to those which governments would like them to go. So then it is clear how much special rapporteur can achieve during such a visit.
Thank you. Can I ask you to join the panel here with us? Let me just, again, their biographies are in your material. We have Sophia Gruskin. I see. You can go. You can take it. That's fine. Wendy Mariner, Dan Tarantola, and Michael Groden. And first, let me ask our new panelists whether they have any comments or questions for Danis. Oh no, you don't have to have. I have questions if you don't. Go ahead, Wendy. Yeah.
Sure, I can begin.
Okay.
I really, my goodness, okay, all right.
Just for you.
Exactly, thank you. So I really appreciated your perspective, and I really appreciated the framework you set out. And one of the things that I think many of us struggle with is whether the right to health or whether health-related rights are really what we need in order to achieve the outcomes we want. If the right to health itself is sufficient, or whether we need attention as well to a range of other rights in order to make health in order for people to ultimately be healthy. And I recognize that my perspective is that we need a range of rights. And I understand that as a rapporteur, your focus is on the right to health specifically. And I wonder if you could comment a little bit about that. I guess. Is that how you want us to do it?
If you want to comment on it, it's fine. Anybody else can comment on that too. That's a central question, obviously, right? Do we concentrate just on the right to health, or do we have to necessarily work on it? Yeah. Since you're the rapporteur of the yourself, yes, exactly.
I try to reach some internal consensus, compromise. I understand that I am rapporteur on the right to health, but I cannot stop myself from moving more broadly, and this is my conscious position that I probably don't believe in this very narrow interpretation. Other reason is why, for example, I have a lot of people representing organizations representing LGBTI groups are very much interested in my mandate, because my mandate appears to be the only one in all the system which can somehow address this issue. So I think it's my duty to address this issue, although I know that when I address this issue, many governments will tell that I overstepped my mandate. But I think that I do not, because these all violations of human rights of LGBTI people are health-related. So this is my justification.
Yeah?
A quick comment on the same line. One of my previous bosses, Director General Gro Brundtland from WHO, used to say, there is not, or there should not be any Minister of Health. Every minister is a Minister of Health. And I think that really conveyed a very important message, that the holistic view of human rights is quite central to the concept of health. And I noted in Daniel's presentation here that he mentioned the so-called rights-based approach to health only once, and in the last slide, as if he was paying tribute to those who sort of cast this concept earlier. And I want to ask you, is the concept losing some of its initial meaning or value? The rights-based to health, just to give you a short commentary on this, put off people in the health sector. They put them off because they felt that now public health, medical practices was going to be guided by human rights instead of public health being inspired by or consistent with human rights. So the concept of public health being sort of overtaken in a way by human rights was not very popular in the health field. And this is one of the reasons why WHO was the last agency in the UN system that devised its own health and human rights strategy. All the others had done so. So my question to you is human rights still, the rights-based approach to health, or approaches to health, is it still a valid concept, or is it something that you would prefer to refer to as health and human rights?
Well, again, it is about very different interpretation of or expectations from stakeholders, how they see right to health, how they see this mandate. One thing is to be in the meeting with civil society, and then they raise, I should say, only human rights issues related to right to health. Another thing is to talk with representatives of governments who would like to separate somehow human rights from from health policies and public health and see this as a technical issue. Maybe not very directly to your question, but I just this morning was mentioning to Sophia, 2 high-level events will take place in not far from here in April, and both I think are not, should be better, should disappoint people, will disappoint people like me, and I think like you. On gas, it's about drug policy, and you know that there were many expectations that it's time for human rights to come back and to this important issue, and to change this failed war on drugs, but I think this will not happen. And there will be very high-level event in Washington, D.C. on mental health, WHO and World Bank, where there will be no single word about human rights. It will be about cost effectiveness of treatment of mild cases of mental health problems like anxiety and depression. And persons with psychosocial disabilities are not. So it was some technical decision, but I think that it was not very good decision to leave out human rights issues even when mental health is discussed. So again, I think that there is some conscious or unconscious conscious or unconscious desire to push human rights to the margins and not to mainstream. Also in WHO documents sometimes we see that, and human rights also is important, so which should not be so. And just to finish this comment is that when I started, and we have in induction session, like for new rapporteurs, there was panel with several ambassadors, and we were asked to be free to ask any questions in like private. So our question was to ambassadors: is universal human rights principle still valid in Human Rights Council? And more than half told that no, it's not. No, it now depends on culture of the country. So I think it's not a very good tendency to forget what happened during World War II and how declaration was born in 1948. People tend to forget this.
Michael?
To comment on the central organizing, grounding nature of health as an organizing principle, I think it's important to remember that health is seen as a precondition for whatever one's life goals are, whatever one wants to accomplish. One wants to be healthy, insofar as one can be healthy. And how much human rights contributes to that, or healthcare contributes to that, is an open question. But it's a primary good. In that regard, everybody needs it and everybody wants it. What's different about that as a primary good, as opposed to food and shelter, which everybody needs as a precondition as well, is that those are predictable. And everybody needs it, and everybody needs a certain level of it and a minimum amount, whereas health is a different kind of creature. Also, health is similar to education in that it increases your range of opportunities of what life goals you might choose. So, I mean, I think health is a basic primary good that has elements that are similar to those other primary basic goods and different.
Wendy, yeah.
I was very pleased to hear and read your description of the concept of the right to health as embracing all of the social determinants of health, which I think many in this room are supportive of. And I think that also helps to, at least in theory, avoid the hierarchy of rights, because by addressing housing and income and education and all of the things that do contribute to one's health, it enables people to address the sources of health and obstacles to health across the board. So I'm very pleased to see that. I think that's an exciting concept that most of the people here are interested in. How far has it gotten in your discussions with other countries? I mean, do they pay lip service, or do they still consider the right to health to be limited to health medical care?
You mean country visits?
Yes.
I had only 2 so far country visits, but both were so impressive. In 2 weeks I go to Algeria. This will be my 3rd country visit. I think it's the best what can happen in rapporteurship. Because I was in committee on rights of the child. It was also interesting, but it was just staying in Geneva. And when you go to visit, it's so important. Of course, there are many painful meetings, especially with civil society. Sometimes these meetings are confidential, and but people representing government take this seriously. Discussions are serious, not necessarily with highest level people, not so often highest level people, but especially interesting for me is to talk with doctors who are trapped in some dilemmas when the legislation or when there is some discriminatory laws, and how it's so interesting for me as a doctor to discuss with doctors. Like in Paraguay, imagine a doctor who tells, but this is nothing wrong if 10-year-old girl is pregnant and will have a baby. Nothing is wrong to her physical and mental health. So this doctor is sort of forced to think so, because otherwise, he or she will be in problem. Or in Malaysia, they still have caning, and the pediatrician is invited to participate in procedure and to tell when to stop. So it's, the doctors are put in such a difficult situation, or when undocumented migrant comes to hospital, they have to perform duty of doctor to assist delivery, for example, but then as citizens of Malaysia, they have to inform police. And police comes and brings this mother and baby to migrant detentions. And so this conflict created by abusive laws affects medical profession also. The medical profession is in a very difficult situation. But maybe it was not exactly what you asked. It was about how political will is presented. I should say that the very fact of invitation already is good, that they invite and they usually provide the opportunity to go where rapporteur wants to go, like it happened with me. In Paraguay, I decided to visit in each town where I was. I decided to go to school because I was a little bit fed up of going to hospitals. What can you see in a hospital? In each hospital, people have very good equipment, especially in capital. So it's no use to go to a hospital in capital. And why schools? You're a rapporteur on health, not on education. In the end, everybody agreed that these were most successful visits to schools, to speak with children and teachers about life. And there is no single phenomenon in life which is not health-related. So we were talking about health. And in Paraguay, finally, one girl told loudly that they want to know more about sex. so it was good.
Just maybe a couple of comments. The sort of extra sectorial dimensions of health, so-called social determinants of health or drivers of health, were first cast in a document in the year 2000 in what is called the General Comment 14, which sets out very clearly, I believe, the fact that health is not a health sector affair only, but it extends to all other sectors that contribute to health and benefit from health. So there is a two-way relationship there that is very practical, very important. The same document gave some very explicit interpretations of what the right to health meant, because there were lots of disagreements as to how to interpret the various wording. And so that, I think, should be either updated or revisited to make sure that we build on it rather than casting a new interpretation of the vast dimensions of health. The comment I would add is that I think people who work in public health and human rights here, and others who are not in this room, I think should take a little bit of the blame as well for the fatigue that has built around health and human rights issues. The number of guidelines, the number of documents, the number of academic publications is so overwhelming that for a government to make a rational decision, it's become impossible. And so I think, I remember, for example, when the CRC came out, UNICEF was identified as the holder of that, the Convention on the Rights of the Child, was the natural convener of the promotion of this right. The first thing that they did, and I have lots of respect for those people who work on this project, produced a 1,200-page technical document telling people, governments, and NGOs what to do, how to implement the CRC. And very frankly, I went through the first 50 pages and I could not go on. And so that I think tells us that we have to be succinct, we have to be focused, we have to be modest, and to reach out with the appropriate language and the key messages, and perhaps not be too impressed by the fact that there should be no competition between rights, because in real life there is competition between rights. When you have $1 million to invest, the choice is there to you as a government to invest in health and education, or else in education and transportation, or else, and so forth. So there is indeed a sort of competing priority setting that matters as well.
Yeah, Sophia, I just love that term, health and human rights fatigue. I hadn't heard that before. But I can understand what you're saying. You get too complicated in trying to explain and direct.
And I'm going to respectfully disagree.
Okay, good.
Okay?
That's all.
No.
Okay?
That's why you're here.
Okay, so...
You don't have the right to do that.
There you go, exactly. but I have the responsibility. Okay, all right. So I think I absolutely agree when it comes to messaging. And that in terms of messaging, that the messaging got too complicated over time. And so in that context, I think that the notion of what gets translated to governments needs to be succinct and needs to be rethought and needs to be packaged in a different way. But where I disagree is on the operational. And I think that one of the problems is that if we want to move rights out of the rhetoric and we want to ensure that rights are fully implemented, we have to give people the tools to be able to do that. And that isn't a messaging piece. That is actually probably not a 1,200, 1,800 page document, but I don't in any way want to support the idea that we just go back to kind of streamlining sort of very clear messaging. And I don't think you mean that, so, or maybe you do, but I just...
Find out.
Okay.
If I may, George,
Yeah, of course.
a brief comment, and I'd let my colleagues here also speak. A brief comment on the chronology that you showed us here, which is very useful, the sort of the sequence of phases in the history of health and human rights. There was, I think, around the 1989 fall of the Berlin Wall, something very important that happened that may not be appreciated from a public health perspective the way it should be. I think that what happened then is that, or what happened before that, you had two ideologies that were really, constantly in a head-on collision. And this was so simple to manage. We eradicated smallpox thanks to the fact that there were 2 blocks in the world, and they were competing. And there were some working in friendly countries, others in friendly countries, etc., and smallpox was eradicated. There were many other factors why it happened, but the fact that the block structure of the geopolitical world was there was one of the reasons why it worked. Then the wall collapsed, and there was no more ideologies. So people started to look for alternate ideologies. Human rights certainly emerged as a possible framework for rebuilding global ideologies. And they were interpreted, but that's the time that also coincided with sort of maturing HIV growth of the health and human rights concept. But you had that. Human rights certainly appeared as a potential, if not definitely valid, way to frame global policies. At the same time, religious extremism, radicalism, etc., also grew in that vacuum that those 2 blocks, having disappeared, had created. And so today we are perhaps at a time when there is some leftover of that interest towards human rights, but the momentum of that era is perhaps eroding a little bit. And we have to make sure that we stimulate it again.
That's great. I want to actually take a break for about 10 minutes. We're going to come back to the panel after that, think of questions. I want the panel to actually respond to something that our rapporteur said, that in mental health, we often use the power of the state to compel treatment. And is that really ever justified? I want you guys to talk about. And those are competing values.